Hello, everyone. I'm Dr. Carmen Puliafito, and I'm here today with Dr. Arshad Khanani of Sierra Eye Associates in Reno, Nevada. He is also clinical professor at the University of Nevada Medical School in Reno. Arshad, welcome back to Retina Synthesis.
Thank you, Carmen. I always enjoy our conversations and looking
Yeah.
forward to our discussions today.
So you were a Faricimab pioneer. After it was approved, you were one of the first in the U.S. to use it, and you organized a phase 4 trial, the Truckee Study, which is a real-world trial looking at how faricimab was used. So tell us about Truckee.
Absolutely. So as you know, Carmen, Truckee is a town next to Reno and also a river that goes through Reno. So we decided to name it Truckee. But the idea of the study was that, Tenaya and Lucerne phase 3 studies looked at patients who are naive. And we know that when a new drug comes out, it gets used broadly, and most of the patients that get initially treated are previously treated. And we also want to establish safety of the drug in a much larger real-world patient population, because as you know well, there are inclusion-exclusion criteria in clinical trials that exclude many of our patients. So the goal was to do a non-pharma supported, so this is collaborative, this is all my team and all my friends around the country helping with the data collection to look at the real world efficacy and safety of faricimab in all patients with neovascular AMD, previously treated or naive. And, recently, as you know, at ASRS, I presented the 3.5-year results from the Truckee study.
How many eyes and how many clinicians were involved?
So we have over a dozen sites. Many of the names are involved in this, and it's been a long-term journey, and they've all done a great job volunteering the data set. We have 3,675 eyes of 2,916 patients in this 3.5-year data set with 21,338 intravitreal injections. So this data set is getting quite large. We kind of have stopped new patients entering last year so that we have about 3,500, 3,600 eyes we want to focus on for long-term data in terms of long-term, outcomes with faricimab. So the numbers are not going to change as we go forward, but rather we're going to get longer-term data on these patients.
What were the entry criteria?
There were no entry criteria. Any real-world patient with neovascular AMD, whether he's naive, whether it's previously treated, any treatment in the past, whether it's aflibercept, brolucizumab, ranibizumab, whatever treatment, everybody was included in this study. And obviously, when you look at the demographics, majority of the patients were previously treated, and in this 3.5-year data set, 42% of them were on aflibercept. So we are getting a lot of switch data from different anti-VEGF in Truckee, as well as naive data on new patients.
So what were the 3.5-year findings?
So what we did, Carmen, was we looked at, because it was an ongoing study with patients coming at different time points until we stopped the recruitment of new patients last year. We have to look at outcomes on an injection basis and then the overall outcome. So we're looking at patients who received 3 injections, whether they were on any prior anti-VEGF. Then we looked at patients who are on aflibercept and how did they do. So we looked at patients who received 3 injections switch or 3 injection naive. Then we looked at 6 injections of faricimab over time. Then we looked at 9 injections of faricimab. But there was just a consistent story. The consistent story has been that patients who were previously treated, when they were switched to faricimab, that improvement in anatomic parameters, whether you're looking at intraretinal fluid, subretinal fluid, pigment epithelial detachment, or PED, they all got better. Their CSTs got improved. And then in terms of vision, we saw maintenance of vision in switch patients, because as you know, many of these patients have already maximized the visual acuity gains. So we saw disease control with faricimab. The other thing we saw is that we were able to extend these patients longer than their prior interval. Specifically, if you look at aflibercept patients, which was about 42% of the switch patients, or all patients actually, you see that you're able to add 2 more weeks on top of what aflibercept was getting, in addition to improving the anatomy and maintaining visual acuity. And we saw that effect kind of, plateau after 6 injections. So at 9 injections, we saw similar outcomes that we saw with 6 injections. So the idea is that, with VEGF-A and Ang2 inhibition, our hope was that we'll be able to extend patients out by targeting another pathway. And we are seeing that in these real world switch patients on prior anti-VEGF. So adding 2 more weeks to somebody that's coming in, every 4 to 5 weeks, the average previous interval, when you look at aflibercept, was about, 40 or something days, and we were able to make it close to 55 or 60 days. So I think we're adding 2 more weeks, which is meaningful for patients who are high need. And then naive patients did really, really well. When you look at naive patients, they had robust visual acuity gains. They had significant improvement in anatomic parameters right off the gate. One thing I've noticed with faricimab in naive patient, Carmen, is that the rapid improvement that happens in fluid resolution, many or majority of the patients get dry after first or second injection, and that's what we saw in Tenaya Lucerne. And when you look at the 9 injection effect in naive patients, we had 10-letter gains in real world, which is pretty significant, and it's actually higher than what we saw in Tenaya Lucerne. And part of it was that there was a range of vision there. Here we include everybody, and we had about 110 micron of CST improvement and a reduction in PED height. And after 9 injections, these patients are, extended quite far already. On average, what we have seen in naive patients, that they can go up to 10 weeks with faricimab on average after 9 injections. It was actually 76 days. So we continue to generate this long-term data where we are seeing the efficacy of targeting the additional Ang2 pathway. And the one thing I want to see over time, Carmen, is maintenance of visual acuity in these patients. So currently in Truckee, over 3.5 years, we have seen, slight decline of vision over time, which we know can happen because of atrophy and other parameters. But, on average, we are able to maintain visual acuity within 1 line for the previously treated patients. To the data we have, over 10 injections, it went from 58 to about 55. But in naive patients, we saw about 1 line of improvement. So the hope is that hopefully with less treatment burden, patients will get enough injections that we can not see the steep decline we see in the real world over time. But obviously we have to collect that data. But the extension of treatment interval data is pretty impressive. We are seeing that faricimab is making a difference in terms of extending the treatment interval for all patients, whether naive or previously treated.
How do you use faricimab these days in real world clinical practice?
Very good question. So if I have an IE patient, I'll give them faricimab. They come back in 4 to 5 weeks. If they have no disease activity, I'm extending. I'm not loading. As you recall, in Tenaya Lucerne, patients were loaded with 4 faricimab injections. So most of us are actually trying to, extend the patients quickly, because I think we see, as I said, majority of the patients, in my experience, actually go dry after the first or second injections. And so that's what I'm doing. If they come 4 or 5 weeks, they're dry, then I'll add a couple more weeks and then keep moving them forward. There's actually a study that's going on looking at that. It's called the Constant study that's currently recruiting, which is a phase 4 trial. And of course, it's a sponsored study that is looking at trying to extend patients, quickly and further than 16 weeks. So we'll learn about that data set in the future. But I think I have changed my habits after what I've seen with faricimab in terms of rapid disease control after the first or second injection.
If they're dry on at 4 to 5 weeks, when will you see them back?
Yeah, so that's a really good question, because in Tenaya Lucerne, you got 4 injections, and then based on the algorithm, we would go 4 weeks at a time. In real world, if you got dry after 1 or 2, I want to be a little bit tighter initially, so I usually go 2 weeks at a time. If I'm loading the patient with 3 or 4 monthly shots, then I'm comfortable going a month at a time. But for patients who are not being loaded, which is many of the patients I'm seeing that go dry, I would add 2 weeks at a time.
That's exciting. What about safety?
Safety is, an important part of Truckee. It was initially a safety study because what happened with brolucizumab in the real world, we wanted to make sure safety looks good. So when you look at the number of patients and these, 21,338 injection, if you look at the per injection IOI rate, is about 0.08%, and the endophthalmitis rate is 0.028%. That's per injection rate, not per patient. That's how we have looked at the data. Overall, it seems comparable to other agents. I had a patient with non-occlusive vasculitis with Faricimab, and it was an interesting case that we have put it in our safety tables already. It was a patient that was on aflibercept, not controlled, went to Faricimab, developed some intraocular inflammation. So we went back to aflibercept, and the disease wasn't controlled. So one of my associates put the patient back on Faricimab and was doing well, and then suddenly developed this, intraocular inflammation, including non-occlusive vasculitis in both eyes. So one eye was previously treated, the other eye was naive, so they gave Faricimab in both eyes. And then we stopped Faricimab, we treated with PO and topical steroids, and then it resolved and the patient's vision came back to baseline. But the learning from that obviously is that if you're going to get inflammation, you have to be careful to re-challenge, because if it's an immune response, then obviously it's going to get worse. If it's from impurity or something, then it won't get worse. We have many patients who were re-challenged in Truckee, Carmen, that did not develop, recurrent inflammation. But I'm very careful if I have intraocular inflammation. I like to not re-challenge the patient. So that was only one case we have seen of non-occlusive vasculitis in our cohort, and that patient did well.
One question that everyone has is how does it compare to high dose aflibercept, if at
That's
all?
a really good question, and I think you and I and others have to design a study that's prospective, right? It's very hard to compare both of these agents head to head without a prospective study. So I hope DRCR net does that trial for us. But in my experience, I think it's very hard to know whether switching to 8 mg is going to make the patient do better. We had a small cohort of Faricimab high need to 8 mg high need that we presented at ARVO. It was only like less than 20 or so patients, but what we saw was some patients did get better, others got worse. But the challenge with 8 mg, Carmen, is the label, right? So hopefully we get a label update. You give these high need patients monthly 8 mg, and then they may be showing some improvement, but after 3 injections, you have to go back to 7 weeks. So that's why in most cases, the high need patients got switched back to Faricimab, because the label didn't allow us to treat them more often than every 7 weeks after the 3 loading. So hopefully when the label opens up based on the data they have submitted, then I think we'll have better data set to compare long-term, anatomic control with 8 mg in Faricimab treated patients. But overall, I've not seen a huge difference in terms of switching patients to 8 mg in terms of durability or anatomic control. But I think the jury's still out, and I think better studies will be once the label is broader.
Well, thank you so much for your insights and your pioneering work in organizing this trial. Uh,
Thank you,
it's
Carmen.
it's not controlled, but the insights are valuable. And I appreciated your discussion of how you're using this drug in the real world now on the basis of this Truckee data.
Thank you, Carmen. Always a pleasure speaking with you. And it's a big lift, right, when you do these studies. And I want to thank my staff. I have one ophthalmology resident now, Amir, and one med student, Hannah. They have really done the heavy lifting. All my team, and of course, all my collaborators and retinal physician friends around the country. So couldn't do it. It's a team effort. So I want to thank all of them. And of course, I want to thank you for inviting me again. I always enjoy all the episodes of Retina Synthesis.
Okay, thank you.